All right, few questions for our esteemed faculty, and I know we can answer most of them. Steve, you want to take that first?
Yeah. How long does TAVR last? There's really no sign of deterioration yet. So the European experience now is pushing 12 years. In clinical trials, we've got data out to 6 years and a head-to-head comparison with surgical valves. So we have no signal yet of deterioration. So it's a question that everybody's asking, and we'll keep asking it every year until we see something. But so far, they look good.
Well, in the surgical literature, 7 to 10 years is the time frame for deterioration, so that's what we're all waiting on. The interesting thing about science is that sometimes you find that all the things you thought were going to make things really bad actually turn out to make them really good. So as scientists, we just got to wait and see what's going to come.
How much does a TAVR cost compared to open heart, US versus Europe? Our surgeon told you he's cheaper than.
Well, the hospital keeps telling us that it costs them a net loss of $8,000 to do TAVR, and mitral valve repair, they have a profit of $20,000 to $30,000 per procedure.
The hospital likes that comment. So they're very different. So in the box, a TAVR without any sort of cost to put it in is about $30,000, whereas a surgical valve is about what, $4,000, maybe $5,000. So they're very different in the box. Lots of arguments and economic discussions and investigations for the last 5-6 years. The TAVR is basically usually associated with a significantly shorter length of stay, rehab. So it depends really where you're sort of drawing the line on the costs. To buy it, it's absolutely more expensive. If you only compare Medicare to Medicare patients, and particularly if you factor in those patients who have a surgical valve and then stay in the hospital for 3 months recovering, which thankfully we see less of. So the economic comparison is very tough. Mind you, most patients want it, and most institutions do want a TAVR program because at the end of the day, the economies do work.
And I think the place that we're going to see a very big saving is the fact that a lot of these people who are going to head from their house via the hospital into a nursing home and then to death before because of lack of therapy are going to come to the hospital, get treated, and then be able to return to their house and live a normal life at home, taking care of themselves for a number of years. And that adds up to a gigantic amount of savings, which would dwarf any little $10,000, $20,000 difference in the hospital.
Steve, waiting period post-balloon aortic valvuloplasty to monitor effectiveness before doing a TAVR.
So we nowadays do very little balloon aortic valvuloplasty. The reason being these aren't, by and large, rheumatic valves, so there's no expectation that you're going to split a commissure and provide any sort of durable change in the geometry. So if we do a balloon valvuloplasty, it tends to be a bridge to a TAVR in somebody who's very, very sick, like the case Dr. Barker showed, intubated, hypotensive. You really don't have the time, or even you really don't have the time to do the diagnostic studies to even size a TAVR. You have to do a CAT scan, you have to be able to measure the aortic root to get the dimensions and all that kind of stuff. And if they're in acute renal failure, you don't have those options because of the contrast associated with the CT. So I would say, we do very, very few balloon valvuloplasties these days. It's really a rare bridge to TAVR.
I think part of it is there's been, certainly in my experience, there's been a reduction in the number of people that have been allowed to get to that degree of extremists before they're sent in. I think people are recognizing now that if people go into heart failure, you don't want to just sit and watch them. You want to get things moving to try to find if there's something to be done.
And if you're going to see some of the hemodynamic improvement, it's going to be very early, right? So, that's your best bet, and gradually gets worse over time. Any questions from the audience here that, prefer good old-fashioned microphone? There you go. We like that.
So you were saying that, the tower, for TAVRs, you generally don't recommend bioprosthetic under the age of 60. So for TAVRs, would that also be another qualification that if a patient's younger than 60, the TAVR would not be recommended because it is a tissue valve and it would not be expected to last as long as in a patient who's, say 70 or 80?
Go ahead, Gerald.
I think that's sort of the working structure now. Obviously, there's always going to be some group of patients who really want a bioprosthesis, and so there will be some kind of trial that will attract some people who want to have it, and we'll have to wait and see the data. But there's no question that two things really affect surgical bioprosthetic durability. One is young age, and the other is renal failure. So the conservative position will be to wait and probably have to think about slowing down at some point to see what we're sure about the durability in the late 60s and early 70s before we push on down to 60. There's been no change in all the new bioprostheses that have come on the market, all the new ways of preserving the leaflets, all the finite element analysis that's going into analyzing stress patterns on leaflets. All of this stuff, nothing much has changed in terms of bioprosthetic durability in the last 10 years. There's been no breakthrough that justifies suddenly start putting it in a bunch of young people.
So I'll just make the comment, agree with everything Dr. Lawrie said. One of the things that's really changing the paradigm in the clinic discussion is the whole notion that you can do a bioprosthetic valve intervention, whether it's a TAVR or a surgical valve, in that tricky age between age 50 and age 60. The guidelines still say 60. Clinical practice is sort of drifting down to 50 for at least discussing getting a bioprosthetic valve over a mechanical valve. And the reason that's occurring is because people are recognizing there is this valve-in-valve option. I showed you a case of the mitral, but that's one of the most common things we do now in the aortic position is recognize you can put a nice surgical, you can put a nice circular TAVR valve inside a nice surgical prosthetic valve. So if you're a 50-year-old patient and you're thinking, well, it's 10 more years of Coumadin if I wait, or it's a 10-year Coumadin exposure to wait to age 60. It's tough. We don't really know the longevity. We haven't had any patients go 30 years with repeated TAVR therapies. In theory, TAVR at age 50, it gets dysfunctional. You do another TAVR inside that TAVR at age 60, maybe again at age 70. We don't have that timeline in anybody. But there is a notion of sort of Russian dolls. You keep layering, getting smaller and smaller and smaller, and every time you get smaller, the mean gradient goes up and the hemodynamics become less attractive. So we don't know those long-term strategies and what's best, but we do know every single patient who shows up wants a poke in the leg and not a sternotomy.
Along these same lines, if you start with a small LVR floor aortic annulus, then your options down the line will get smaller and smaller, right? And I think, ideally, if a patient's aortic root or aortic annulus is large, I think conceivably that could be a scenario without. All right, I think
Can I ask one more really
yeah.
quick follow-up question for Dr. Lawrie? How does renal function affect the leaflets?
Well, renal patients have an increased risk of calcification in all their tissues. We find all their arteries tend to be heavily calcified. They have many tissues where when you're operating on them, you find calcium in the pericardium, and they just have a different, I don't know whether it's the phosphate level or the calcium level. There's something that makes them calcify their tissues, and the valves definitely tend to calcify. We see this starting as early as 1 to 2 years in some people, and in that slide I showed of my version of durability with the 20% drop off at 6 years, there's a companion slide from that same center with their renal failure patients that had about a 40% failure rate at 5 years in their dialysis patients.
I think that also applies to other inflammatory disorders, severe rheumatoid arthritis, systemic lupus, other things. So you got to be careful about, who to put what kind of valve. So it's an important discussion.
And then carcinoid is another one. We just had to do a carcinoid patient with a mechanical valve. The carcinoid patients have a very bad go of it. Their bioprosthetic valves all fail within 1 to 3 years if you use a bioprosthesis for the tricuspid.
Well, I want to thank you for a lovely morning that you spent with us.